Good afternoon and welcome to the virtual town hall for September 18th. Thank you for joining us. Today we will have time for Q&A, so please submit your questions in the chat box. Let me start by thanking each and every one of you for the healthcare you provide, for your work in all of our missions, and for your compassion. These last 6 months have been difficult. Long hours, a frenetic pace of change, disastrous episodes of racism, social unrest, and more. And at home, a turn of our world upside down. On top of this, there's been great uncertainty. I don't have to list the many sources of uncertainty for you that exist in our worlds, perhaps now as never before. As I was pondering all this, it brought to mind a book I recently read entitled The Good Doctor. A theme of this book is that uncertainty is a core concept in all we do, from patient care to research to education. And my take home from this book was that we must admit uncertainty and be honest and transparent about it to our patients, to our learners, and to all around us, including ourselves. Many aspects of life today bring uncertainty, but none greater than the crisis we, the United States, and the world face in this era of COVID-19. So much of our conversation today will focus on COVID-19, from the clinical trials we're engaged in here at Michigan Medicine to the operational preparations being made so that we can respond to a potential resurgence of COVID-19 cases. Finally, in regard to COVID-19, we also need to be leaders in prevention. We can play our part with vigilance to for preventive strategies. It's likely that we'll also see a number of new therapies, exciting new therapies, a new wave that is of therapies designed specifically for COVID-19, and we can be leaders in this area as well. On to other comments. As you know, Dr. Carol Bradford will be leaving Michigan Medicine for a prestigious position as Dean and Executive Vice President for Medical Affairs at Ohio State, and we will all miss Carol. Brian Zink, who currently works in the medical school as Senior Associate Dean for Faculty and Faculty Affairs, has agreed to serve as the interim Executive Vice Dean for Academic Affairs. And for those of you who have not gotten to know Brian, I'm sure you will in the coming days and weeks, and you'll find him to be an exceptional partner. We appreciate his leadership as we work through the process of finding a permanent replacement for Dr. Bradford. This week, we also shared an updated mission, vision, and values description. The new mission, vision, and values were carefully crafted based on feedback that many of you provided through town halls, through live meetings, and surveys. And I think it's important that we all are familiar with the mission, vision, and values because it does give us a shared purpose and a shared connection. So starting with mission, our mission is our purpose: to advance health to serve Michigan and the world. Our vision speaks to our aspirations for the future and what we want to become as an organization. Our vision is our discoveries change care. Our care changes lives. And finally, our core values reflect the behaviors that we value and expect within the Michigan medicine community. These values are caring, innovation, inclusion, integrity, and teamwork. We recently made the decision to add inclusion as a core value to reflect our efforts and our commitment around diversity, equity, and the elimination of racism and discrimination. My hope is that wherever you are in the organization, in the medical school, in clinical care, in support services, or elsewhere, you can see yourself in our mission and our vision and our values. Many of you have given us feedback about your needs so we could better understand the specific issues and challenges that you face, particularly around dependent care and family care. The Family Care Task Force has taken this information and will be providing recommendations and proposed solutions later this month, at which time we'll come back to you for further input on these ideas. Finally, many of you have asked where we stand in regard to our economic recovery plan. As we've ramped up, our finances have steadily improved, such that to date we are well ahead of our FY21 budget. We're not out of the woods yet, but we're at least on the right path. As I speak with groups and deliver this hopeful news, many have asked about when some of the cuts made during the economic recovery plan might be reversed or relaxed based on our improving finances. Let me assure you that this is top of mind for me and for our leaders. We're actively seeking input as to what would make the biggest difference in your lives, and we'll develop a proposal for the university, which we'd like to present to the UMHS Health Board in our October meeting. Ultimately, it's the university, the health board, and the regents who will make decisions. And if we can continue our outstanding performance, I think we'll be in a favorable position. To close, I'd like to thank you once again for all you do, for yesterday, for today, and for tomorrow. Now I'll turn it over to Dr. Anna Locke to discuss COVID-19 vaccine clinical trials.
Thank you, Marshall. I'm very excited to share with you all what we've been doing as far as some COVID-19 research is concerned. Next slide. So vaccine is obviously something that everyone is very interested in, but early on, we were also involved in COVID-19 treatment trials. And as you can see, we were involved in treatment trials that included antiviral, anti-inflammatory, anticoagulation. We also were involved in trials involving convalescent plasma and stem cells as well. We also built a biorepository that included more than 20,000 blood as well as nasal samples to share with other researchers. And we have multiple data repository as well. In the last couple of months, we were also involved in tier activation of non-COVID related clinical research that had been paused during the early months. And to date, we have about 1,400 trials activated. But more excitingly, we're about to start 2 phase 3 clinical trials of COVID-19 vaccines. Next slide. Many of you have seen the diagram of the virus with the spike protein. So the spike protein is actually part of that virus that allows it to bind to human cells that allow the virus to enter the human cells. So all these vaccines are basically targeted against the spike protein to block the virus from entering the cells and setting up infection. Next slide. There are multiple strategies of developing vaccine, but what is very different and very exciting now is that we actually largely involve new generation platforms that have never been used in approved vaccines. Traditionally, we've used the whole virus, which is either inactivated or attenuated so that they become weaker, or we just use a part of the virus. For example, just the spike protein without the virus itself. However, in the current era, we're using new strategies to develop the protein into the human body. And that included using other viral vectors, for example, the adenovirus, which is like a common cold virus. And that's the strategy employed by AstraZeneca, as well as Janssen, 2 companies in which we'll be involved in those trials. Many of you have also heard of the Moderna virus vaccine, as well as the Pfizer vaccine, and they use a different approach, the RNA approaches. Next slide. To date, there are roughly 35 vaccines in clinical trials in humans and more than 120 that are still in development. So I'm sharing with you data from the AC trial that we'll be involved in. On the left panel in blue, that's the control. These are people who receive a different type of vaccine. And as you would see, they have very little detectable antibody response against the COVID-19 virus. The second panel indicates the people who receive 1 dose. At baseline, they have very low antibody titer. And by day 14 and 28, you actually see a very good antibody titer. The third panel included people who received 2 doses. So after 1 dose, you see an improvement in antibody response. And after the second dose, a further increase. Note that the y-axis, the vertical axis is a log scale. So it's actually not 1, 2, 3, but 1, 10, 100, and 1,000. And therefore, a tiny increase actually represents a major increase. The last panel actually indicates the antibody level in people who have recovered from the infection. And as you can see, after vaccination, people have an antibody response that is similar to those who have recovered from a natural infection. Next slide. So what is the study design? All these vaccine trials compare the real vaccine to a placebo, in this case, just normal saline. The AC trial is a 2-to-1 randomization, so 2/3 of the people are going to get the vaccine, and they receive the injections on day 1 and day 29. They need to come back for 6 in-person visits in total in year 1 to monitor for the response by measuring antibody level in the blood, as well as taking swabs to make sure that they didn't get infected. There's one last in-person visit in year 2 to again look for durability of the antibody response. But during the first year, in order to pick up asymptomatic infections as well as symptomatic infections, the participants will need to track daily symptoms like fever and runny nose. And if they report certain symptoms that reach a threshold, they would need to be coming in for testing to see if they get infected. And if they get infected, they would receive proper care. So what's the primary purpose? We want to make sure that people do make an antibody response, but also to make sure that the vaccine can prevent infection. Equally important is demonstration of safety. Next slide. How do we actually monitor these patients, these participants? Well, nowadays, we use a lot of technology. So there is some electronic tracker. The patients would go to a website and record their symptoms. And if their symptoms reach a certain threshold, there are people monitoring these reporting of symptoms 24/7. The participants will be contacted to see if they need to come in for evaluation. If they do report symptoms that are concerning, we'll give them an electronic device where they'll wrap around the arm, and that will actually monitor the blood pressure, the pulse, as well as oxygenation, so that we know if these participants are doing okay or they're getting worse and they need to come in and be evaluated or even be admitted. So you can see that we're using all these modern technology to minimize burden on the participants, but also to be able to track and collect a lot of data. Next slide. So many of you are very interested, and we are very, very appreciative, because within 24 hours of UMMG Graham announcing this trial, we had more than 1,000 people who sign up. The question that everyone is asking is, do these vaccines help? Will I derive any benefit? Well, we have reasons to believe that they would work. However, at this stage, it's still largely unknown, and that's the whole purpose of doing the trial. Many of you are also concerned, are they truly safe? Well, like all vaccines, they do have some side effects, and the common side effects are really at the injection site, very similar to when you get a flu shot. You get a little bit of pain and tenderness. You might even have a low-grade fever and achiness for a few days. These symptoms tend to be very, very mild. Next slide. Well, other questions that everyone have is, well, I hear that there's a placebo. Well, would I find out whether I got a real deal or whether I got a placebo? At this stage, while the study is still ongoing, we would not be able to let anyone know. However, at the end of the study, after the data is fully analyzed and submitted to the FDA, and FDA has approved of the data analysis, the sponsor will unblind the study, and the participants will be informed. There is also an intention for the manufacturers to make the vaccine available to people who got the placebo. Some of you have asked, what if another vaccine gets approved earlier? How would I know whether I should be getting that different vaccine or not? Well, unfortunately, we won't be able to tell you if other vaccines get approved earlier, because we won't know whether you got a real one or whether you got a placebo, and whether getting additional one would be beneficial or not. I know that this is a very brief presentation, but actually yesterday we had a 1-hour live stream. And if you click on the link, you'll be able to watch that 1-hour live stream and get more information. Thank you very much. And I'm going to now introduce Dr. Dave Spollinger, who is going to continue with the COVID-19 planning.
Good afternoon. Thank you, Anna. I'm going to talk a little bit about COVID update and operational planning, and included in that will include an update on influenza, as well as some of the operating room changes. So next slide. This is from Johns Hopkins resource just the other day. And, the question is, have we flattened the curve? I think two things to think about is that the March-May pandemic was mostly a southeastern Michigan, and what we're seeing now is mostly across, broadly across the state. Also, we had much more testing available now than we did in the spring. Many patients were sent home without testing to ride out their symptoms. So I do think that the magnitude of the March is not really reflective of the disease that was present. And we have sort of flattened the curve. I would say we're on a high plateau. If you go to the next slide, you'll see that, we've been pretty flat in our hospitalizations over, since the spring, though we are trying to prepare for outbreaks that might occur in the fall with schools opening, university opening, and the onset of flu and COVID. If you go to the next slide, we'll talk a little bit about our planning. Now, you've seen this slide before. Hatinder Gurm has been involved in planning this along with the leadership of UH and CNW, and we've been focused on right now we're on a chronic plateau, and we can take care of the 14 to 10 to 20 COVID cases we have in the hospital. But if we have an acute cluster outbreak or a resurgent pandemic, we will have to make some changes. And our goal going forward is to be able to take care of both COVID and non-COVID patients. And that has been a challenge. So if we have an acute cluster outbreak, we'll have to have additional ICU beds. And so we've put together a plan that we're implementing right now, assuming that we'll at least have an acute cluster outbreak. And if you go to the next slide, you can see what we've done. We've added additional moderate care beds to 5A and additional moderate care beds for 6C. We've added 10 ICU, or adding 10 ICU beds in 8D, and additional 6 beds in the trauma burn unit, which we can do right now under the executive order. If that changes, then we wouldn't be able to use the trauma burn because it doesn't meet code. But you can see it involved an investment of almost $3 million in staff, as well as equipment and some minor renovations that we'll need to do in order to increase this capacity so that we will be able to take care of both COVID and non-COVID patients and maintain our elective and medical admissions in the current towers. So that's what we're doing. Now, if you go to the next slide, if on the other hand we have to open the RICU, and that means then we can open the RICU in increments of 16, 32, and then up to 50 beds. Initially, we can open 16 beds with the use of MFH faculty as primary, with critical care faculty backup. We would have to close some units in order to get some of the MSFU, and we will also have to reduce some nursing staff and some of the other UH units to cover the 16 beds. We are still working on the plans for 32 and 50 because you can see the incremental nursing and tech resources that are needed to staff 32 and 50 beds are significant. And in the spring, we were able to use some traveler and premium labor, but because of the widespread pandemic across the country, those resources aren't as readily available as they were in the spring. Next slide. This is sort of our decision-making capacity. It's all driven by the ICU use by COVID patients. So where we are now is, up to 10 ICU COVID patients. And you can see as we start getting into the 20 to 30, we have to then begin to manage our ICU and general care census by prioritizing our transfers. And then when we get closer to the 30 mark or over 20, we have to manage ICU and general care with elective management, which is typically surgical patients. And then we also have to begin to manage our moderate care as we get up higher. Because this is a real possibility that we may have to reduce surgical patients, one of the challenges, of course, is we do not want to go into the fall with a significant delayed care. As you may recall, at the end of May, we had nearly 12,000 delayed surgeries because of COVID, and we've made a effort over the summer with expansion of hours in the ORs to catch up on those delays. And we've largely caught up on almost all of those patients that had been delayed during the springtime. But we're still scheduling 1,600 to 1,700 cases a week from the faculty, and we still have 4,100 of those cases that aren't scheduled, that have been requested in the last 90 days. So if you go to the next slide, this is our current Saturday OR for University Hospital. And you can see that we've started out in May running 19 rooms, and we've now come down to 11 rooms, and we're evaluating, whether to continue offering the Saturday hours. But it does have the benefit of providing leveling the use of our inpatient unit. And it also we don't want to necessarily reduce a bottleneck as we try to get these cases done before COVID hits again. Likewise, we're offering Saturday OR schedule at both Brighton and East Ann Arbor, alternating Saturdays. And there was a drop off on the use of those Saturdays in July and August, but this most recent Saturday, Brighton had 91% utilization of the ORs. So we will be looking at that. We currently only offer about 40 more hours of operative time in the ambulatory surgery than what we were offering in January and February. So we're concerned about stopping Saturdays and creating yet another bottleneck to getting those cases scheduled. Next slide. So first, this is our flu vaccination strategy, and I will apologize that we've been late getting this strategy out and communicating. Communication will go out after this, after the town hall. And in the absence of a communicated plan, I know that there's been justifiable concerns about our policy. Influenza is a significant concern with COVID. If you look over the last 3 years, there's been about 500 to 800,000 hospitalization admissions due to influenza, and 34 to 60,000 deaths been attributed to influenza, and between 15 and 20 million office visits. So the worst thing would be to have both a significant outbreak of influenza and COVID that could really strain our healthcare system. So our goal this year is first to provide a safe environment for people to receive flu shot, but also to increase the uptake in influenza vaccines among our population. Typically, only about 45% of the nation's populace takes the vaccine, and our goal is to increase that. If you go to the next slide, we have used a regional strategy where we will have flu clinics, and our goal, and we have a capacity to administer twice as many vaccines than were given in FY20. We also will be having a communication plan that will also emphasize community resources that are available. We want people to get vaccinated in whatever venue is convenient for them. We're also offering drive-through vaccines and center at Huron Valley Ambulance. Next slide. One other critical thing that we need to do is that for all our primary care as well as our specialty clinics, each in-person visit is an opportunity to also give influenza vaccine. So it's not just the primary care, but it's the specialists, and trying to make sure that people are vaccinated so that we can reduce the likelihood of both a flu and a COVID epidemic. And we also will offer a drive-through where you can get your COVID testing as well as your flu shot. Next slide. This is one of the campaigns and one of the flyers that'll be coming out later today and next week. Finally, next slide. Finally, I know that this has nothing to do with COVID, but it is something that has come up recently, and that is that we had signed an agreement with Fluency Direct, which can provide basically partial dictation for everyone. It replaces Dragon. I've been assured that it basically works as dictation. You can use Haiku or Canto directly into your phone. All you do is press a button and start dictating. You could do partial dictation, full dictation. If you look at the next slide, this is how transcription currently works. You have to dial a phone number and our ID. There's a wait time of 4 to 10 hours, and then you get a draft note. If you go to the next slide, with this, you can enter into the computer, you can use the microphone on the computer, you can dictate into your phone, and the note is immediately available for edit and sign. It also can be used, it will be used on the inpatient, it can be used by APPs, it can be used by residents, as well as faculty. And with that, training will begin soon. It really doesn't require much training. You just use it and it improves you with each dictation. And that's all I had today. And Dolores, Dee Hunt will present some, I'll turn it over to Dee to talk about human resource updates.
Thank you, Dave. Good afternoon, everyone. I just want to start with thanking you all, as we always do, with all the work that you're doing each and every day. It is remarkable how we're able to continue to move forward so quickly after having such a terrible go of COVID. So let me just start by saying thank you for all you do. Next slide. We're happy to say that even though we are not able to come together and do a day like we normally do for Appreciation Week and have ice cream socials and have breakfasts together, we have not dropped the ball with moving forward with doing something that we want to take time to recognize our employees. So beginning next week, we will begin a new virtual appreciation activities for employees to recognize, to be appreciated through some different virtual sessions that we have available. As you look at the slide, you'll see that there's things for everyone: health and wellness, well-being, professional development, diversity, equity, and inclusion, emotional support, and financial resources. We're happy to be able to bring these to you along with donated prizes that will be given away throughout the week, as well as time for you to interact in breakout rooms with your peers. So look forward to all of these activities beginning next week. You can register for any of the events at hr.medicine.um.edu. I've already registered for a couple classes, and I'm excited to be part of the Appreciation Week. It's not how we want it, but it is an alternative to just take a break and relax and learn at the same time. So I hope you take advantage of that. We partner with various departments, including organizational learning, our OHE department, our financial partners, TIAA, and Fidelity. So, and healthy is always part of what we do, to just remind ourselves that we need to take care of ourselves too. There's a lot going on and we're not denying that, but there is a point in time where we just need to step back and breathe. And so we hope you take advantage of these events. Next slide. The other thing we are proud of is a new recognition site that's available. It is real time. It includes making a difference, and some of you've participated in that before. It's fast, it's easy, you can make it fun. We just need you to sign on. You can put your photo on there. You can let people know if you like private recognition or public recognition. But it is something that we're encouraging all our departments to consider hosting with their own teams, as well as you can recognize anyone, because every day people are making a difference. And we know that recognition is just the art of actively looking for efforts, large or small, that makes a difference in our world. And right now, people wouldn't mind a little recognition for going that extra step, making that certain patient or that certain coworker feel more comfortable as they go through various things in life. Again, it's easy, it's personal, and it can be immediately in their files. And all they have to do is log online to recognition.med.umich.edu. We hope you take that opportunity to use this. You can use our core values that's just been recently rolled out earlier this week. It aligns with making a difference. So if you see someone exhibiting great teamwork, let them know that you saw them. Many people don't know that they are being seen. This is a way for you to send a quick note to say, I saw you today. I saw you exhibiting teamwork. I saw you caring. So take the opportunity to go in and recognize someone, and it will be much appreciated by them. So we have a couple things going on here. We have our recognition site. Next week, we have our recognition program. And I ask that you sign up for both, participate in both. If you haven't signed up, go to that site that's right there. You'll see information in our headlines. You see an article there this week with a link. And we're also trying to put it in various places throughout the websites so that you can have easy access to it. So I hope you take advantage of it. We're excited about it. We've had many use of it. In just one day, we had over 1,000 people participating. So we hope you'll be one of those individuals. Thank you again for all that you do. And at this time, I'm going to turn it over to Keith Dickey, our Chief Strategy Officer. Keith?
Thank you, Dee. So I will be moderating the Q&A in the chat. We've had quite a few questions coming in. I'm going to do my best to batch them, and then any questions that we don't get to, we will of course try to follow up and cover in our weekly communications. So let's see here, and please bear with me as we try to go through these. Let me start with Dr. Spollinger. We've got a number of questions related to the flu and the flu strategy. The first one, there are concerns that multiple clinics do not have staffing to run flu influenza vaccine clinics. How does plan to address this? If we are not able to ramp up vaccination for routine vaccinations like influenza, how will we manage vaccination for COVID?
Well, I think we have put in place a vaccination strategy at each of those regional sites. That information will come out this afternoon and next week. There are going to be Saturday clinics, Sunday clinics, and all-day clinics that we've put staff in at those. We have been trying. We do have challenges with staff everywhere. We have 50 openings in environmental services. We have 20 openings in the call center. We have a number of MAs and others, and we are working with HR to try and talent management to try to recruit those. But we do have a plan that would allow us to vaccinate twice as many people as we did last year. And so that, and part of it is consolidation in a regional strategy in order to accommodate that. I think the other thing we do have to do is try and vaccinate at each personal visit when a patient comes in, and take advantage as an opportunity to vaccinate.
Thank you, Dr. Spallinger. A few more related questions. Please explain why non-clinical workers who are working remotely, and in this particular individual's case, fully isolating, are required to expose themselves to others to receive a flu shot.
I couldn't hear you, Keith.
I'm sorry. The question is, please explain why non-clinical workers who are remote and are required to expose themselves to receive a flu shot. And this particular individual is actually really isolating in place.
Yeah, so I think that that's part of the reason that the flu clinics have been separated out from the clinics and at regional, is that we want to make sure that, one, that there's masks, that there's social distancing, that there's cleaning protocols for each effort in order to provide them with a safe way to receive vaccines. And so our belief is that is very safe to get the flu vaccine.
And you mentioned in your presentation drive-through flu clinics.
Yes, and we will have a drive-through.
Is that for patients or for employees?
No, that's for patients. We're encouraging employees to use the employee, but you could use that for employees. We want employees to try and use our flu clinics that we've created with occupational health, which we believe are safe also.
Very good. And will patients be able to self-schedule flu shots?
Yes, and we will, and they will be able to do that also through the portal.
And lastly, at least for the moment, Dr. Spallinger, will staff be required to get the COVID vaccine when it's publicly available?
Well, we don't. First of all, we haven't developed that policy yet because we don't know. We don't have a vaccine that we know of that is effective, and I know that there's been some discussion about a vaccine being available within the next month or so. That seems unlikely. We are working on who would be the high risk. There'll have to be developed an algorithm as to who's high risk to receive the COVID, because I anticipate there won't be vaccine for everybody.
Okay. Very good. All right, Dave, I think I'll let you go for a moment here. May come back to you. Dr. Locke, we had at least one question regarding the AstraZeneca clinical trial. And also I should note a number of folks have asked if the link that you shared in your slide will be made available. And I assume the answer is yes, we'll get that out.
Yes, that certainly would be shared with everyone.
The question is, will patients
I can't hear the question. Can you repeat the question?
I'm sorry, I fear my connection may not be as good as it needs to be. The question is, will patients who are participating in the AstraZeneca clinical trial be exposed to virus to evaluate if they are protected?
They would not be. So we're not going to purposely expose or challenge the participants with the real virus to see if they're protected. We have various ways by which we can tell whether they are protected or not, because we'll be comparing infection rate in the people who received the vaccine with those in the placebo group. We recognize that not all infections have symptoms. There are certain tests to determine if people might have been exposed to the virus, even though they do not have any symptoms.
Thanks very much, Dr. Locke. I think for the moment, unless as I catch up on questions, I think that covers the question related to clinical trials. Thank you very much. Let's see here. Dee, I've got at least a couple questions for you if you would join. Let's see here. First question, when will promotions be allowed to be given to employees? If so, will merits be allowed to be associated with a promotion?
As Marshall said at the beginning of his introduction, and we are continuously improving, and our hope is that we can start to look at how we can reinvent some of the different things that we paused on. Right now we have a hiring pause. So if there's a clinical position, as Dave mentioned, with MAs or call center techs or radiology, we have to proceed with hiring those individuals. So if people are transferring into those positions, they just got their degree, that's one thing. But as of yet, we have not released or decided that we're at the point to say anything about starting our merit programs back up again.
Let's see, in addition, Dee, actually, I'm not sure whether this is a question for you or for perhaps Dr. Spollinger, but we have a question. Do we have a plan to decrease the wait times on hold for our call centers?
I don't know if you're safe and you just want attention because you look perfectly fine, Justin.
I can just, Dave, you want to go ahead?
Oh, yeah, I think there's a plan. It's just, it's the challenge is that that we've hired some temporary services to try and help with the call centers, but we do have significant number of openings. I mean, we have people who are off, we have people who have left the organization, and so so we have a contract with some temporary services to help out, but we're working with HR and talent management to increase the recruitment there. But we have the same issue with environmental services, have the same issue with radiology techs, have the same issue with a number of areas. So we're trying to, farm techs, same thing.
And Dave, while we have you, two more questions. U of M recently released plans to conduct daily and weekly COVID testing of its student athletes. Is there any plan to do the same for Michigan Medicine employees?
You know, there is not. And I was just on a call this morning with the chief medical officers and health systems across the state, as well as after a visit 2 weeks ago from Deborah Birx from the National Task Force. And the challenge is that we expect to have continued shortages of resources, whether it's reagents or supply chain issues for our testing. And also the other thing that, that people haven't talked about, lab techs are especially molecular technicians have, been really challenged. You know, the lab is running 24/7. People are doing a lot of overtime, and they have a certain amount of training that's necessary under CLIA in order to perform these tests. So I think we will, and if we have another resurgence, we will need to use more resources. We currently have the capacity to do 30,000 tests a week, but you know, some of the bottlenecks are actually, you know, the personnel, as well as some of the other supply chain. And you never know when something, you know, won't show up, that a cassette for a machine won't show up and you have to use another platform. We have about 5 different platforms, so we have redundancy, but it's going to be a challenge. So I think the focus will be on symptomatic. It will also be on employees who have had exposure, and patients, and making sure that we test all the patients in order that the employees, so that we know who is COVID and who isn't COVID positive for all the procedures and people in the hospital, so that we can protect our employees.
Thanks very much. And Dave, a short, quick question. When is the Fluency technology going to get rolled out?
And it's supposed to start in February. That's when the Dragon contract, which we've struggled with, runs out. It is much better than Dragon, but we want to begin it actually earlier, maybe in December, and begin that training, so that we're not, so there's a, you know, so that there's a significant overlap.
Good. And then lastly, at least for the moment, when patients do get their flu shots at one of the regional sites, can they also get other vaccines like pneumonia, Tdap, et cetera?
I will get back on that. I don't know that.
Okay.
Fun.
Thanks. I'll let you go for the moment then. And then Dee, could you come back for 2 more questions? One, are reclassifications also on hold, and also the ability to use recruiters during this time? That seems challenging to recruit staff.
If those are critical positions, we're asking that they go through your administrator, your executive, and what happens at that point, we discuss that with them to share some information such as an SBAR with that information, so we can make those determinations. Yes.
Good. And then one more, can we expect more job loss, which I presume means RIFs?
I hope not. We are preparing for a surge, but we hope that if that surge comes, we'll be able to maintain who we have, since we still have some shortage in spots, as Dave just mentioned. So our goal is to keep going forward, so we can move past this. So let's hope not.
Thank you. Let's see here. One more for Dr. Locke, if she can come back. Great. Thank you, Dr. Locke. If the phase 3 studies we are participating in are successful, how long could it be before a vaccine was available to the public?
If they're successful, we expect that we'll have the results probably end of this year. But it will still be some time before the vaccines will become available. And as Dave mentioned, when the vaccines become available, although every company is geared up to mass produce, initially it wouldn't be sufficient for everyone. So there will be a tier approach who will be high priority.
Okay. Very good. Thank you, Dr. Locke. Okay. Let's see, we have a number of questions related to our financial condition. So I think first Paul, and then Dr. Runge. So Paul, if you could join us. We have a general question. Let's make sure Paul's able to get on here.
I'm here, Keith.
Very good, thank you, Paul. We have a general question, is can you provide greater detail regarding the improved financial situation of UMHS?
So it's a broad question, so I'll try to address it. When we were going into our projections for fiscal year 20, we had anticipated a loss anywhere from 130 million to 230 million at the health system. We ended up at a $21 million loss, which was much better than we expected. That loss was supported by $118 million of CARES Act funding. So we ended up at that 130 range because when we made those estimates earlier, we did not anticipate governmental funding. So right about the 140, less the 118 brought us to 21. So that was the first step of an improvement. That said, that was still about $200 million behind where we had planned to be for 21. 2 months into August for the health system, we are at about $35 million better than we had expected to be. And when I use the term expected to be, that's the governance approved budget. We had budgeted for this year, so 12 months ending June 30th of 21. The budget is $53 million positive. We are at about $49 million through August. So we are back on track to be where we expected to be pre-pandemic. And so as long as our patient activity continues, as long as we can continue to manage the expense environment appropriately, we feel pretty good about our ability to be back on track this year. So in summary, we will have lost fiscal year 20 in terms of expected performance and hopefully getting back on track this year. But again, that's 2 months in, and we hope that the next several months will continue on this pace.
Very good. Thank you, Paul. And with that, then I have a series of questions for Dr. Runge related to that update. See if I do not see his
I'm on.
Okay, very good. Thanks for joining again. So related then to our current fiscal situation, one question. I know the president and regents will need to approve any proposals, but what proposals for financial relief are your priorities, e.g. retirement funds, CME?
Let me answer that in two different ways. I think it's the major changes that we need to get approval for. For instance, if we decided to look at restoring the retirement match, that's something that would have to go to governance. Other changes that are of much lower magnitude probably do not. We have a series of facts, FAQs. It's a long list, but if you go all the way down to the bottom, there are comments on use of discretionary funds in various ways that I will clarify many questions. And I've been having discussions with the chairs, and we can have discussions with others about continuing medical education and professional development. I would say that the most complete answer right now is this is in an early phase of discussion. I have had one discussion with governance, and it's, but this will be a continuing discussion. And in reality, we need to be able to assure ourselves and our leadership that the trajectory we've seen in July and August continues at least for the first quarter, which would be through the end of September. And we generally get our financial results around the 11th of the month, 10th, 11th, or 12th of the month. So I think we'll have a better idea of where we stand at that time. And that's when we'll be able to have more significant discussions with the UMHS board and the president, for example.
Thanks. And I think you've already answered this question with that answer, but the question here is, when will discretionary funds be unfrozen so faculty members can use them again?
Yeah, so there was both, I think, misunderstanding and I'll own that, about what can and can't be, what discretionary funds can and can't be used for. So if you go to that list that I mentioned that's in the FAQs and or talk to your chairs, they can help you with that. But in general, discretionary funds are available to fund ongoing research and a variety of things that are fairly specifically addressed in that list. And Steve Kunkel also, who's on the call, can also help with those questions. And other potential uses. I'm happy to hear about other potential uses if they're not covered in those FAQs.
Very good. And here's a question of clarification. Many leaders took elective compensation pay decreases when the magnitude of the financial impact emerged and staffing cuts were needed. Have Michigan Medicine leaders' compensation been restored?
Nope.
I can concur.
I can tell you that definitively.
Yeah, I just want to make sure that's clear. Let's see here. And again, very much in the same tone, but let me give you the opportunity to answer this. Now that Michigan Medicine is seeing encouraging numbers for the beginning of the fiscal year, is there a process in place to reevaluate units that have suffered rifts and continued heavy workload?
So that is a really complicated question, and I'm not trying to punt it, but that to answer that question really takes a discussion with both Dave Spollinger, who's overseeing all the operations, with Paul Castillo. The easiest, a transparent answer from me is we can look at anything, but I think we have to be strategic in what we look at. And for instance, if we do have the flexibility to increase our spending in one or another area, what I'm certain about is we can't increase it in all areas. So we'll have to prioritize what we do. And I'd be the first to say that there are many areas in which we have needs. One thing I've been telling people as I talk to them about the budget is we were told at the end of March, I think the end of March, that we needed to reduce our expenditures by $400 million. And we needed to provide that budget in 2 weeks. I think if we'd spent 2 years, we wouldn't have gotten everything perfect. And we certainly didn't get everything perfect in 2 weeks. We did the best we could. I think that was, at the time, I think that was a blunt instrument. And now we need to be much more precise as we look at how we make further adjustments to our economic recovery plan. So that's not very specific, but that is, that's where I would like to see us go it'll be over the coming months.
Great, thanks. Let's see. This one, again for you, Marshall. Why only the hospital system's retirement match eliminated and not the campus at large?
Well, it wasn't just the hospital, it was the medical school also, which is interestingly part of the university. Let me just say this. This was a topic that was discussed. There was much discussion about it being across the board for all employees of the University of Michigan. And we proceeded in that manner. That didn't happen, as you know. That was one of the largest components of our economic recovery plan, but it's also one that we can look at early on. Again, please don't take any of this as commitments. I'm trying to be as transparent as possible, and that is that I can't make commitments about these things, but this is not a recurring cost reduction in any regard. There was never, and I think I've said before, I commit to you, we will not, under any circumstance, continue this after July 1st. So we're talking about whether we can make changes before July 1st of 2021. Also, let me make one other comment. I think during any time, it's important that I have a chance to hear from you and to provide answers that are as clear as I can verbalize them and as transparent as I can be, and I will do that. I am in the process of going around meeting with departments, but I'm happy to meet with other groups of individuals. One of the one of the benefits of the Zoom era is that I can meet with groups fairly easily. And if there's a group that would like to meet with me, Rose Glenn, who is on the call, is our Chief Communications and Marketing Officer. So I'm pretty booked up for the next few weeks, but I'll continue to try to do that.
Great. I think that brings us to the top of the hour. So if you have anything left to close out with, Marshall, I think we have a number of questions that we're going to have to take up in the written communications.
Well, I'd just say this. We've come a long way during a very difficult time in all of our lives. And I feel confident that we can accomplish more together. I feel confident we can achieve our aspirations. And to use a poor metaphor, we may be in an era of cloudy skies, but it's after the rain that you find the rainbows. Like I said, that's a pretty poor metaphor. I'm no writer or English major, but I think that there are better times ahead, and we need to continue thinking and working together as we are, and already and continue our core values and our missions, as I talked about earlier. Thank you.
Thank you all.